Hello, everyone. I'm Priscilla Ryan Harris, co-founder and director of operations at Black Health, an Atlanta-based nonprofit focused on advancing health equity in Black communities through anti-racist education, advocacy, research, and programs. And welcome to Black Health Ask a Doctor, Fertility Equity for Black Families, in partnership with Morehouse School of Medicine's Center for Maternal Health Equity. Today, we are gathered to address the unique challenges faced by people in our communities on their journeys toward parenthood. Black people encounter fertility struggles nearly twice as often as their white counterparts. These challenges stem from centuries of systemic oppression, limited access to affordable care, and implicit biases within the healthcare system. Our goal for this conversation is to delve into the cultural, societal, and healthcare barriers that impact Black reproductive health. We are here to foster an open dialogue, share insights, and explore strategies to improve fertility experiences and outcomes for Black families. We have an amazing panel of speakers today, and I'll allow each one of them to introduce themselves and their roles, starting to my right.
Hi everyone, I'm Dr. Lasha Clarke. I'm a social epidemiologist, a birth doula, and the Assistant Director of Research and Translation at Morehouse School of Medicine's Center for Maternal Health Equity. I'm super excited to be here and to be in conversation with these lovely folks today.
Hello everyone, I'm Dr. Desiree McCarthy-Keith. I am a fertility specialist and I'm the medical director of Shady Grove Fertility here in Atlanta. Also very happy to be here, so thank you.
Awesome. Hi everyone, my name is Khadija Amin and I am co-founder and director of policy and research at Black Health, and I'm so excited to be in conversation with you all today.
Hey y'all, my name is Amanda S. Wicks, PhD, and I am a reproductive health advocate and a birth worker.
Hi, I'm Paula Wheeler. I'm one of the co-founders of Black Health, and I'm the director of creatives and communications at Black Health.
Thank you all so much for introducing yourselves. See, told y'all we had an amazing panel for y'all. So before we get into the conversation, I want to start it off just a little light with an icebreaker question. And so the question is, if you could invite 3 people to your dinner table, who would they be? And so I will actually start with Paula.
No, you know I'm one. It's the least prepared for some reason. Okay, so the only person I could think of, like, off the top of my head was Kalela. She was, like, one of my favorite singers. And I think she's so, like, interesting and, like, I just want to know more about her. Like, I want to know, like, what's going on, like, her story. So I invite Kalela. And then I kept thinking Solange, I think because y'all were kind of talking about Beyonce. And then because I know that they're cool, like, like Solange are kind of cool. So I'd be like, oh, I want to hang out with y'all. And then my third one, I think I would say maybe like my grandma, to hear more of her life story. My mom's mom, I want to talk to her some more. Yeah. That's good.
Hey.
Okay, that's my dinner table.
I like your dinner table.
You took one of mine.
I'm sorry.
I always said the only celebrity I would ever want to be is Solange, just because she's like low-key enough, but she's able to do really whatever she want to do. Multi-hyphenate creative. So I said Solange, Toni Morrison. At first it was like a level of seriousness, but I'm like, I feel like she goose off sometimes, you know? She know how to have fun. And then, exactly. And then my third one was really hard, but I threw in the artist Bisa Butler. She makes like beautiful quilts. I'm just fascinated by everything she creates. So I would want to know, I'm like, how do you do this? Because I can't fathom how she approaches her work.
Those are good.
Yeah. So I cheated a little bit. I only have 2 people, and it's Victoria Monet and Janelle Monet.
Well, that's good.
My
good
Monet
combo.
sisters, bisexual icons. But I feel like they would be really fun to have a conversation with.
Yeah, for sure. Very good. Okay, I'm going to copycat just a little bit because I would love to have dinner with Toni Morrison. She is my favorite author. Beloved just changed my life. So I'm like, if I could just talk to her and just, I think that would be fascinating. I really need to meet Stevie Wonder.
That was going to be one
I
of
think
them.
he is like the greatest performer of all time, and I would love to just sit with him. And then I want to sit down with Barack Obama. I just want to talk to that brother. Like, how was it? How was your life?
Right.
What it just, I think he's so smart. I think that would be fascinating. Yeah.
Sure.
Yes, I think so.
Yeah, these are some good ones. I was going to say Toni Morrison, so I will take her as well. She's going to be booked and busy during our and my other two, my first one I would say is also my grandmother. So my grandmother I never met. She passed in childbirth, having my mom. And so kind of, I know we're trying to keep it light, but also to bring it back to this conversation of maternal health, I'd love to meet my grandmother, and then I think I'd also have to invite my mom so that she could have a conversation with her mother as well.
Wow.
I love that.
Yeah.
Hey, and now I'm like, I kind of feel like now I'm still in yours because I started thinking about it too. So I was gonna definitely invite my mom. Like, that's my best friend. Love my mom. But similarly, her mother passed when she was young, so she doesn't really have too many memories of her, and I'm named after her. So I would love to like meet her and have a conversation with her, and then I would just throw Beyonce in there because I love Beyonce, and who doesn't want Beyonce at dinner? The mother dinner table.
I love that. Oh, that was beautiful. I feel like it just really all came full circle of what we're here for today. So, yeah, just to really introduce this topic, we always like to start with some level setting, just so we all know kind of like what we're talking about. We're on the same page, our viewers as well understand. And so we want to start with you, Dr. McCarthy-Keith. What is infertility, and what kind of challenges, when we talk about infertility issues, what are the range of challenges that people might be experiencing like that? Can you tell us a little bit more?
Yes. So we always define infertility as the inability to conceive for a certain period of time. And it's really based on a woman's age. So when women are 35 years or younger, we say if you have unprotected intercourse regularly for 12 straight months and haven't gotten pregnant, that's infertility. Once you're over 35, we shorten that to 6 months of trying, and then we consider that to be infertility if you haven't gotten pregnant in that time frame. The reason that we have the cutoff is because the age for ladies matters so much when it comes to our fertility, more so than men. For men, if their testicles active, they make fresh sperm from scratch every couple months, over and over, until they're 50, 60, 70. So we all know men who are 65 and have a baby all the time. But for ladies, our egg count is highest before we even born. We have 6 or 7 million eggs in our ovaries before we are born, about 20 weeks pregnant. By the time we're born, our egg counts dropped to about 1 million. We lost most of our egg supply in utero, and from the time we're born, we don't replenish that. So from birth, our egg count is drifting down slowly. So once we get into our 30s and close to 40, our age really impacts our egg reserve, our egg quality, and all those things. So that's why we have the cutoff between 6 to 12 months. But it's unprotected intercourse for 6 to 12 months of trying. And then when I see a couple, we always break it down to, could there be a factor with the eggs, egg quality or ovulation? Could there be a sperm factor? And we know that there can be sperm factors in 40 to 50% of couples. So it's not that we just test women and then we look for a male factor if we don't find anything. Men can have fertility issues almost equal to women. And then there can be anatomic factors, whether it's blocked tubes, fibroids, endometriosis, and things like that. So those are some of the general categories that we think about when we see a couple who's having trouble getting pregnant.
Very interesting. Yeah, I actually didn't know all of that.
Right.
So, yeah, and I know, Mercy, you mentioned the stat that Black families experience like fertility struggles at like twice the rate of like their white counterparts. And so when we talk about these health disparities in fertility, I know Morehouse School of Medicine Center for Maternal Health Equity, you all are doing research on this. So Dr. Clarke, can you tell us more, like, paint the picture for us of what these types of disparities look like, what are the struggles there?
Yeah, so it's pretty much just as Mercy said. The data really show that Black families and Black women, in this case I'll say it's what the data are mostly around, are twice as likely to report infertility, but roughly half as likely to actually enter treatment for infertility or seek care for infertility. And so that sets up the disparity really right there. And then in many instances, once Black women do enter care for infertility, first of all, it's more likely that we're entering care with some sort of other conditions that have an impact on our fertility. So things like uterine fibroids, which we know are more predominant among Black women than women of other races. And then we're also more likely to discontinue treatment or to have worse treatment outcomes than our counterparts of other races. And so that really just sets up this entire context where from beginning to end, once we've sought care, before we seek care, once we sought care, and after, we're at, in ways, a social disadvantage in this way, and are having kind of these social and systemic barriers come into play as we're trying to build our families.
Yeah, yeah. And at Black Health, like, it's really important for us to explain, like, what we mean when we say racism causes poor health outcomes. So I'm hoping Khadijah, our policy director here, can you kind of like, you know, take us through that, like paint that picture for us as well of like, when we say racism are causing these health outcomes for Black families and fertility outcomes. Can you explain how that's operating?
Yeah, absolutely. So just to step back and define racism. So racism is a system of power that structures opportunities and assigns value based off of how someone looks, so their perceived racial category. And due to racism, Black people, Black families are less likely to have opportunities to access high quality and affordable fertility support and services and education. So for example, Black people are more likely to be and underinsured, which impacts our ability to afford fertility supports. While also racism structures our community conditions and overexposes us to health harms, such as environmental stressors, and those can have a detrimental impact on our reproductive health, on our fertility outcomes.
Yeah, absolutely. And we know like racism isn't the only thing that Black people are dealing with. We have a lot of different other identities that are also operating in our lives. And so can you tell us more about just like how like intersectionality, explaining that concept and how that's also operating here for fertility outcomes?
Yeah, absolutely. So as you mentioned, racism isn't the only system of power that is operating. So for Black folks, for Black families who experience the detrimental impacts of other systems of power like classism and sexism and queer and transphobia, they face even more barriers to accessing quality and affordable fertility support. So for example, when we think about Black, queer, and trans people and families, they're facing not only racism, anti-Black racism, but also systemic queerphobia, transphobia, structural stigma that's really impacting their experiences as they navigate our healthcare system.
Yeah, and I would add on to that too, that a lot of that comes through in what we see in the data that are collected. So on a national level, a lot of the time the data are really centered on, when you drill into it, the data that's there are on married, heterosexual women of childbearing age. And so while we get some information, we're missing information on huge populations of people, or really just meaningful populations of people that also have struggles sometimes with infertility, who we can't really tailor our interventions or research or whatever it may be, or clinical practice around if we don't actually have that understanding of what their needs are. And so that just highlights the call to really see what's going on across these intersections, right? So not just among Black women, period, but among Black women of different income, different education, different sexual identities, different sexual orientations, and Black people more broadly, not even just Black women.
And what I would just say is that representation matters. And so if we are not seen in reproductive medicine as providers, then we don't even feel comfortable to connect with our providers, or if we don't see ourselves represented in the patients who are going through the care. So a big area with infertility is that fertility treatment really became more popular in the United States in the early 80s. And many of the campaigns for fertility care didn't reflect us. The posters and the outreach was just white, middle-class women. So if you were a Black woman who was having trouble getting pregnant and all you saw was white women are the ones who do fertility treatment, you said, this must not be for me. Black women don't have infertility, and we were just not even a part of the conversation for so long. So that also kept us away from, seeking care or even being comfortable to share that we were having trouble. When we talk about access, even in states where fertility coverage is mandated to be covered by insurance, we still see that Black couples go through fertility treatment less. So while financial is one aspect of it, there are cultural and societal factors that still keep us from being underrepresented in fertility care.
Yeah, I think to your point, Dr. McCarthy-Keith, it's like there's a lot of things just like in our cultural beliefs around like we're strong, Black women are so strong, and then Black people, like we're so viral, our virility, and like, you know, so the idea of like struggling with your fertility is just not very like a popular concept or notion to even know, or like there's like a lot of shame kind of around that, you know.
Exactly. And I just want to take this moment for anybody out there who's listening to shift the blame. There's no blame on you for dealing with infertility. There's no shame in the infertility game. Kind of going off of what Dr. McCarthy-Keith mentioned in the kind of definition of infertility, it's a disease. It's a dysfunction literally of the reproductive system. It's not a social thing. It's not a repercussion for X, Y, or Z that has happened earlier in your life. It's not a spiritual issue. It can have kind of, you know, things to do with all of those things, but at the end of the day, it's a disease and it needs to be acknowledged and treated literally as such.
Absolutely. There's no judgment in infertility. Sometimes women feel like if I lost a pregnancy earlier, if I terminated a pregnancy when I was in college, am I being punished now because of things? And it's not. There's no judgment in this. Like we said, it's a medical condition, and we have to focus on that and focus on the treatment to correct that.
Yeah, thank you both so much for saying that. I really do think people need to hear that for sure. And Amanda, you know, it's so funny. So Amanda has been like a friend of Black House for a while now. You're very supportive. You come to our events. And so I actually didn't know that you speak openly about your fertility struggles. Mercy brought it up. She had seen you talking about that. So I just wanted to know if you could tell us more about your journey with your fertility struggles, and just if you resonated with some of the things we've been talking about, you know, as your like personal experience.
Absolutely. So for those who don't know, which is pretty much all of y'all, my husband and I were trying to conceive for about 4.5 years. Very early on in my life, I knew there was probably something wrong with my reproductive system. It was broached, a topic that was broached with my gynecologist multiple times. Granted, I've seen many gynecologists over the years just because I moved a lot, but every one of them pretty much dismissed any questions I had about like, why is my period like this? Why do I feel like this every month? Like, why this just doesn't feel right? And it was just, that's normal. It was always, that's normal. And so I found that no one cared until I was trying to get pregnant, which is another problem. But even then, I brought up the topic of wanting to conceive with the gynecologist that I was with at the time. And she kept kind of kicking the can down the road. Well, let's wait until we do this or that, or things that had nothing to do with it at all, which just prolonged the process. We went well beyond the year. Because she wasn't taking me seriously, pretty much. I'm like, I already told you I have this issue. You already see I have this issue. I was officially diagnosed with PCOS, that's polycystic ovarian syndrome. And so I was officially diagnosed with that, which made a lot of stuff make sense. But she wasn't even interested in that. She was just like, let's make sure you don't have breast cancer. Let's make them like, this has all been checked before. So, you know. It actually wasn't taken seriously, or we didn't actually start to get the help that we needed until my husband went to a urologist. And he did everything to get tested for male factor infertility potentially, which actually was a factor for us, which we never would have known. So it wasn't until that urologist recommended us to a fertility specialist that we could get the ball rolling. It took way too long.
Took a man.
It took a man to go in. I'm like, oh yeah, this is an issue. Y'all should go get this. Okay, like we could have been there. But that was also good to know, because that was something that didn't necessarily cross our mind, was the male factor infertility, which is extremely common. So we were dealing with factors on my side and factors on his side. And in this process, I've had many fertility treatments, multiple rounds of IVF. And similarly, to the topic of, you know, we see white middle class women did not think it was in the realm of possibilities at all. I'm like, that's only rich people get IVF.
Right.
Like, that's, which I mean, it is extremely expensive if you don't have any coverage at all. Even if you do have coverage, it is extremely expensive. We spent thousands of dollars before. Thankfully, I got a job that covered IVF, right in the thick of it. So if it wasn't for that, I can wholeheartedly say we would not be able to afford it. There were so many barriers, so many insurance barriers still, even when it's covered. But yeah, the process just was always wrought with somebody kind of dismissing us, somebody saying like, no, let's just wait, let's just see. I'm like, we already know. Like, like just listen to us and let's get this ball rolling. So we've gone to many different fertility clinics. We were in Houston at the time. Many different fertility clinics. We landed on one here, thankfully, but it was definitely a long journey for what I felt was no significant reason. Like, we definitely could have gotten here a long time ago.
And I just want, you spoke to so many things, and you know, I'm glad that you finally received the care that you needed the whole time, but there's so much bias in the medical system. And you know, if providers also buy into only white women do fertility, so if they see a black woman sitting in front of them who's saying, my periods are irregular, I've been trying for years, haven't gotten pregnant, they sometimes say, but black women are fertile. So I'm just going to tell you, keep trying. Just, you know, do this, change your diet and things like that. Whereas if a white woman sat in front of them and said the same thing, she would be referred faster. They've actually done studies where they surveyed physicians, OBGYNs and primary care and different folks and said, you know, this is a black woman who's been trying for this period of time. This is a white woman. Who do you think is more likely to have infertility? They said it was the white woman, but we know the statistics are that it's a black woman. And so if we don't even see you as someone who could potentially have infertility, then we are going to kick the can. And that's unfortunate. I'm glad that your husband was evaluated because, like I said, there's male and female factors. Sometimes it's a factor on one side, but many times it's a combination. So you should always start, if you've been unprotected for more than a year, got to check on the male and the female side if there's a male or female partner together to get to the bottom of that. So I'm glad that you were able to get care and be successful.
And I'm grateful that I have a partner who was willing to go down that road, because that is also another barrier, especially for black men, when so much is attached to your ability to procreate, you know, your manhood, ego, everything is at stake often. So I've seen personally many people who are unwilling to go get checked just because of that. So I also want to empower the men to go forth and be okay with addressing those types of issues too.
Yeah, we see that in office all the time too, where we say, okay, the woman can go through x-rays and ultrasounds and blood work and just rounds of testing, and then we say, okay, we just need you to produce a semen sample in the cup. And then sometimes men are just, I don't do that, I can't do that, how am I going to do that? And they just really are, I think, afraid of what if it comes back and says that there's something about my sperm count. What does that mean about me as a man, and you know, as a black man, what does that really mean? So sometimes they're resistant a little bit of coaching. Like, she's gone through all this testing, I need you to give me a sample in a cup, please, so we can check on that.
Right, and that speaks to like all of these levels. We have these social and systemic factors of racism and medical mistrust and, you know, hundreds of years, if not more, of that really validate why these experiences of discrimination are happening and why we feel hesitant sometimes to seek help. But it also speaks to this cultural piece where, like, now for us as women or as men or however it is we identify, we also have to kind of get informed in ways that might mean we have to unlearn some things we thought about ourselves, or unlearn some things we thought about our people. Where it's like, okay, just because I have female reproductive organs and they're not working right, it doesn't mean anything necessarily about my womanhood. It means I need to go to the health for them. Similarly, for somebody who has male reproductive organs, and a lot of that comes down to like these kinds of conversations, like that we can have with each other and just remove that stigma, break that silence, and just start talking about this thing that we don't talk about. If we're not talking about it, then we are not armed with that information that we need to move forward through our reproductive life course. And one of the things that stood out to me, Amanda, in your story is what you were saying about how the topic had been broached with your gynecologist or your life course, which on one hand is a positive thing because for so many folks, it's not talked about. We can rattle off ways to prevent pregnancy all day, right? Because we learn that in high school or even earlier, but it's harder sometimes to get the information that we need and to feel heard and seen when we actually are talking about fertility and having those conversations with your clinician. So I'm happy that they were broaching the subject, even though maybe you weren't getting the treatment that you needed and the next steps being taken at the speed that they really needed to get taken.
Awesome. Yeah. So as you mentioned, Dr. Clarke, we've had a rich discussion about the different systemic barriers impacting Black families regarding fertility support and treatment. So we talked about those macro level factors, racism as a system of power, patriarchy, and how that impacts fertility outcomes. We talked about healthcare barriers. You shared your personal experiences. And so something that's really important to Black Health is to talk about solutions and strategies. So we wanted to transition the conversation to some strategies across levels that can advance fertility equity. And so I wanted to start with you, Paula. So at Black Health, core to our mission is addressing racism and its impact on the health of Black communities. And one way to do that is through anti-racism practices. So could you define anti-racism for us and how it relates to advancing fertility equity?
Yeah, so Khadija, you already told us what racism is, but I want to even go a bit further. You know, we often teach about Dr. Kamara Jones's 3 levels. And so the 3 levels of racism. So it's the internalized racism, which is kind of like those internal negative beliefs that a lot of people of marginalized groups will have about themselves and other people in their group. It also looks like internalized feelings of like superiority that people of the dominant group will have about themselves and people who look like them. And then there's also interpersonal racism, which is at that level, that's usually when you say racism, where most people's minds go, is that like hate crimes, you know, the way one person to another will express their racist feelings and beliefs. And then there's institutional racism, which is operating in our institutions, our workplaces, our schools, our networks, policies and practices. And so at Black Health, you know, like you said, we really believe in being anti-racist. And so what that looks like is really it's an action. It's identifying where racism is operating and how it's operating, and then intervening in a way that works against the way that it's operating on those levels. And we particularly try to focus on that institutional level because that's where you'll see the most kind of like bang for your buck when you focus on the institutional level. You know, if you direct your programs and things like that to kind of intervene on that institutional racism level, then you can also have like a domino effect on the interpersonal and the internalized piece as well. And another framework that I know, like I'm sure everyone here is familiar with, but just, you know, for our viewers, is the social ecological model, which we've definitely been touching on already, right? And so as public health practitioners, we're taught about the social ecological model, which just tells us how, like as individuals, how our environment is like influencing us and interacting with us. And so it gives like a description of like the different kind of like levels and atmospheres of our environment. So it's also similar to kind of like the levels of racism. It's like the individual, interpersonal, your social networks, as well as organizational. So your workplace, like I mentioned, church, other like social organizations, community, which encompasses like this cultural piece that we've been talking about as well, our cultural norms, our neighborhoods, our cities, and then like the policy level, federal, state, and local policies. So we're taught as public health practitioners, again, like to intervene on as many levels as you can, but to try to push your programs to go higher up on that social ecological model. So to try to, instead of focusing, we say this all the time, like we don't focus on individual behavior change. Like, so I'm trying to tell people like, you eat healthier, you do this, like that is much, it can be helpful for an individual person, but when we look at like population level change, that's much less effective. We try to focus, particularly our programs that are around, our anti-racism trainings for current and emerging health professionals. That's for Black Health. That's how we're trying to focus on these organizational, our policy agendas, getting to the policy level. And so when we turn to fertility equity, right, like we can have programs that provide funding for people to get the care and treatment that they need for their fertility challenges. And that's extremely important and beneficial. But I would just encourage, there to be more robust programs that then intervene at these higher levels. So really pushing on our state, local, federal policies that make it healthcare more affordable for everybody, right? That make it so that there are more fertility clinics in Black and low-income neighborhoods, so that they're more accessible, so that there are more Black, compassionate, anti-racist medical providers in those neighborhoods as well. Just all of like these, just doing these broad, like more population community-based type of changes that we really need to see to make it just, really solve this problem for Black communities. So that's how Black Health, that's how we always try to orient ourselves and our work. And yeah, that's how we like to frame our solutions and our conversations. Yeah.
Thank you for sharing. And yeah, in terms of addressing racism, one important tool is research and data as a way to really uplift the strengths and needs of Black communities. So I wanted to pass it to Dr. Clarke. Morehouse School of Medicine Center for Maternal Health Equity is doing really critical work and research around fertility equity to really inform those systems level practices and policies that Paula mentioned. So could you talk more about the research you all are doing around fertility equity?
For sure. So in about 2021, we started what we're calling our Fertility Equity Study, and it's funded by Fair Pharmaceuticals. And our goal there was really to understand the experiences that Black women and Black families are having as they navigate their infertility journeys in their own voices. And so that part of in their own voices is and was a huge component of this study, because we really just want to amplify what folks are experiencing, not put our own words to it, not their own voices overlaid on it, but amplify what your experience is. And use Black women, and in the case of our study, we interviewed folks who identify as Black women, use Black women, and see Black women as legitimate sources of knowledge production. That's a phrase that I get from Dr. Dana Ayin Davis and her book on reproductive injustice, just to plug that. I didn't kind of make that up, but that idea that we are legitimate sources of knowledge production. Our lived experiences are valid sources of knowledge for ourselves on what we need to do to make our individual lives better, but also what can be done on all of these larger levels, interpersonal, social, political, even, to improve our lives. And so all that to say, we surveyed a few hundred women just to get things like, age, education status, what's your insurance coverage looking like, et cetera. What are some of your psychosocial determinants? So things like, what is your stress level? How's your social support looking? Going back to what you were mentioning or getting at around the strong Black woman idea, how much of that resonates with you? Because all of that, whether we feel it or know it or not, it's internalized. It's coming through in ways that we sometimes don't even quite realize physiologically is tied up back to the stress that we feel and our identity sometimes as Black women. So that was the survey. And then to really amplify the voices and get those rich details on what is really going on over your life course, over your reproductive life course, we did interviews with about 40 or 50 of the women that we surveyed. And that has been just such an extremely enriching and rewarding process, both for ourselves as researchers, and also I would love to say for the participants who, at the end of some of those interviews, we're just so grateful to have had a space to share their stories. And that just highlighted how little we talk about this, how much momentum we need to keep going around this conversation, which is kind of what this is all about. And so many folks, you know, who are on their infertility journeys didn't just start kind of where I am today. They went back decades to like when I first got my period, when my mother was experiencing this, when my grandmother was experiencing that. And so we see kind of the intergenerational determinants as well of the things that we're experiencing. Again, to destigmatize this, to take the shame and the blame away. This is not just about us as individuals and what's going on in our lives or what mistakes we feel like we've made or what lefts we took when we should have taken rights. It's a larger issue that now we're putting into its correct context so that we can then move forward in an informed and really directed way to get the families and have the families that we want. Another thing I'll say, and there's a lot of findings that have come out from that study, I can blab on and on about it, from which we've already alluded to, but another thing I'll say that kind of speaks to what you were talking about, Paula, and what you were talking about also about Khadija, is that we are viewing infertility and fertility in general as a human rights issue, as a reproductive justice issue. And so reproductive justice is a term that was coined by women of color, trans folks, and others back in the 90s. And it's defined as ultimately our rights to bodily autonomy, so doing what we want to do with our bodies, our right to have the children that we want to have, not have children if we choose not to do so, and to parent the children we have in safe and sustainable environments. And that, we've heard a lot about reproductive justice in terms of abortion care, which is hugely important, in terms of the maternal mortality and maternal health situation, particularly here in Georgia, which is super dire and super important. But we can also see how it's related to infertility and fertility as well, and see this infertility struggle as on that maternal health continuum. So if one of our reproductive rights is to have children, if we want to do so, that's fertility right there, right? So it's not a social issue, a you issue, a me issue. This is a rights thing. You have a right to have the children you want to have, and therefore that means you need access to the people and treatments that will make that possible for you. And not just access, but then you need to be able to like know about those things. You need to be able to afford all of those things. And so together, which I think we'll get into a little bit later, but together with some partners, including SisterSong and Spark Reproductive Justice, we're really delving, who are huge in the reproductive rights and justice spaces. Our center is now kind of amplifying that approach, this reproductive rights approach that really gets back to like, okay, let's zoom out and think about what we can do on a policy side so that we can have this population level impact. So that whatever we're doing individually is amplified by what all of these other change makers are doing at these levels over us.
Absolutely. And related to advocacy and the importance of advocating for systems change, policies to advance reproductive justice, I was wondering if you could speak more to Black Infertility Awareness Week and the work y'all are doing there.
For sure. And so Black Infertility Awareness Week, first of all, is happening for the very first time this year from July 29th to August 4th. And we at our Center for Maternal Health Equity have been brought on as a partner of SisterSong, and our colleagues there are really kind of leading that charge in putting this week together. And so I do want to say National Infertility Awareness Week has been a thing now, I want to say since 1989, and that was started by Resolve. However, when we think about these, and that's important, right? And that was back in April and happens every year and has happened every year since then, and I think got recognized by Department of Health and Human Services in the 2010s as like a national week that kind of is on calendars and things like that. So that's what we're moving toward, hopefully, with this inaugural year. But why this Black Infertility Awareness Week if we already have a national week? And that's really because of all the things that we've been saying. There are these disparities that specifically affect Black families. And that means that we need to amplify what's happening with Black folks. It's not that these are not universal issues, not that other people don't struggle with infertility, we know that they do, but there's special attention that needs to be paid where there are experiences that are being marginalized, where there's disproportionate negative outcomes and things like that. And so that week is coming up, starting on July 29th, and there are a number of programs and events that SisterSong and other partners will be putting together. And so I encourage anyone who wants to find out more to go to SisterSong's Instagram, and that's at SisterSong_WOC, which stands for Women of Color. Their SisterSong, I'm not even gonna say the name correctly, but go ahead and go to their Instagram at SisterSong_WOC to find out more about all of the events that are happening really throughout that week. That are really framed around this as a human rights issue. And the last thing I want to say about that I want to plug is that in addition to kind of looking at this on the policy level and on the systemic levels, they're also seeing, that we need help sometimes on an individual level. It's expensive to go through these treatments, like you said, and like and like you also know Dr. McCarthy-Keith as a practitioner. And so one of the things that SisterSong has worked with partners to do is to be able to offer $40,000 of fertility treatment. Wow. And so they're offering that in a raffle. And so you're able to go to their IG and get all the details and sign up for the raffle. And then the winner will be announced on August 1st after a screening of Eggs Over Easy, which is the film that Keisha Pulliam executive directed or produced or something like that. So we're super excited to be offering that incentive. That just makes one burden less so. Like we have all those other things to worry about, but that just makes us one burden less so, and that's for our Atlanta-based folks to get treatment here in Atlanta.
Okay.
Wow.
Excellent.
Awesome. That's amazing.
Very good.
And speaking of treatment options, access to treatment, Dr. McCarthy-Keith, could you speak more about some of the existing fertility treatment and resources that exist for Black families?
Absolutely. So we have, we always start with if there's a male and female partner in the couple, but we do a basic evaluation, which, like I mentioned, we test for egg reserve for women. We do a semen analysis for men. We look for any anatomic factors with an X-ray called an HSG to see if the fallopian tubes are open or blocked. We do ultrasounds to look for fibroids and make sure the uterus looks normal shape and size. Based on the outcome of those tests, then we talk about treatment options. So for couples where the tubes are open, the ovaries look healthy, and a woman is ovulating, or maybe she's not ovulating with PCOS or things, but there's activity in the ovaries and there's a normal sperm count from a partner, or for LGBT women who use sperm from a donor, or single women who use sperm from a donor, we can start with insemination treatments, which is called IUI for intrauterine insemination. And that is where we can monitor a woman's cycle, give her medicine to get her to ovulate if she's not ovulating. And then when she's close to ovulation, we can take sperm from a partner or a donor and inseminate or place that in the uterus with a small catheter. It's like a pap smear procedure. It takes about 5 minutes to do. That's kind of the first level of fertility treatment that we offer if the testing is pretty clear. We just want to kind of boost the natural fertility process. We do sometimes get to in vitro, which is the next level of treatment. It's more involved, it's more invasive, it can be more expensive. And that is a way to take the natural fertilization process that naturally happens in the body and take that into our laboratory. So women will take hormone injections for about 2 weeks to stimulate eggs to develop in their ovaries. We put the woman under anesthesia, pass a needle through her vagina into her pelvis, and we aspirate or drain those follicles and take the eggs out of the ovary. We can take microscopic eggs and sperm from a partner or donor into our laboratory, combine them in an incubator, and we can watch under microscope as the eggs fertilize and grow into embryos in the lab. Embryos develop about a week after sperm and egg are combined, and at that point we can pick up a microscopic embryo, pass that through the cervix, and place it directly in the uterus where it needs to go. That's like a two-second IVF. That's all we do for IVF. So we offer that treatment if the tubes are blocked, so sperm and egg can't really connect in the body. If there's a male factor where sperm are present but maybe at a lower amount, so we're worried that enough sperm are not going to be able to travel to the ovulated egg. Or sometimes if patients haven't gotten pregnant with IUI, then the next step is to move up to IVF. Another great thing that we can offer with fertility treatment is genetic testing of embryos. And so that's called PGT, which stands for pre-implantation genetic testing. And so I take care of many couples who might carry a sickle cell trait or things like that, and they don't necessarily have infertility, but they want to make sure that their child is not born with the genetic trait that both parents carry. So you can also do in vitro. We can take those microscopic embryos in our laboratory and test the embryos, make sure it's a healthy embryo. You can know the sex of an embryo, make sure there's no Down syndrome or chromosome conditions. And if the parents have a genetic trait that can be passed on, we can actually test an embryo for that and say, this would be a baby born with sickle cell disease. That's not the embryo to select. And we can go to an unaffected embryo, and that can also make a difference in treatment outcomes. So those are kind of the big categories that we offer. There are many scholarships, grant programs, like you mentioned, SisterSong has a raffle that's coming up. Another support group is called Fertility for Colored Girls. It is a national organization of fertility support for us. It was started by a Black female reverend in Chicago in 2013. Her name is Reverend Stacey Edwards Dunn. I worked with her for many years. And so Reverend Stacey, she had a tour called Black Fertility Matters 2, TOO, in 22, where she went around the country. She came to Atlanta, and we just had seminars for education. There were raffles and gifts associated with that. They raise funds and also award scholarships for couples who can have assisted fertility treatment. There's another support group called the CADE Foundation, which was founded by Dr. Camille Hammond in Maryland. From her own fertility journey, she started this foundation, which is named after her mother. Her story is interesting because Dr. Camille had infertility and went through several treatments, and she actually did in vitro, and her mother carried her embryos for her, and her mother actually delivered her own grandchildren, and now her children are students in town. They're in college. And so from her experience, she started the Cade Foundation, named after Tabina Cade. And they are in for education, awareness. They also raise funds and award scholarships to couples going through fertility. So we have resources available to support us. And it's really just about education, awareness, representation. We have to make sure that we get the information that we need, and then we need to participate. We have to remove the stigma that Black people don't do these type of treatments. Yes, we do. We need to seek out people who look like us and connect with some of these support groups so we can share the lived experiences of other individuals and couples to know that it's okay to talk about this and to go through these type of treatments.
Thank you for sharing. So we talked about policy strategies, research, healthcare. So I wanted to talk to you, Amanda. If you could share some of the work you've been doing around digital advocacy and really storytelling. Dr. Clarke, you had mentioned the power of stories.
Yes.
So how you've used your story to advocate for change.
Yes, with fertility or infertility, I found that a lot of people have no idea that it's even a widespread issue. Even the women who are going through it, or the couples who are going through it, have no idea until they get into the thick of it and maybe start seeking those resources. And so one thing that I found to be important was just talking about it. So we talk about awareness, huge. So I use my platform to talk about it as much as possible because I was somebody who did not see myself in those treatments. Did not know that there were treatments leading up to IVF. I'm thinking like you just go straight into like this most expensive thing you could possibly pay for.
I just learned something new today.
Right, exactly, like with IUIs. Like I even tell people, I'm like, there's a step like before this, and they have no idea, mainly because they haven't gone to the doctor yet, or haven't gotten as far as like talking to a specialist, or maybe they've been kind of passed along from specialist to specialist too. And so I use my platform to talk about what I've personally gone through, since I pretty much have done like all the types of treatments, to just bring awareness to like what's available, even the resources, because my first round of IVF was funded by a grant. And so I know the importance of that because we wouldn't have been able to start without that grant. And so I try to bring those things directly to the people. And I found that every time I speak about it, there are like a bajillion people saying, me too, me too, me too. People who I personally know would have never known that they were struggling with it or even did IVF or like anything because they don't talk about it, which they don't have to talk about it. But I feel like that's like my personal mission to just bring awareness to it so that people can start supporting those policies, start supporting the grant, start supporting all of those resources that come to help women who need it. And so that's something that has become like a passion project for me, even with my Protect Black Mamas kind of campaign, so to speak, because I got into birth work because I was definitely afraid of childbirth. So I had to overcome many like mental barriers, psychological barriers to even being comfortable with birthing a child myself as a Black woman. And so I use my platform to kind of amplify those issues and just bring awareness to the fact that this is something that we should all be concerned about. It could be anybody. It probably is somebody you know, you know, which I think people have no idea. And so, yeah, like that's something that I've picked up and kind of put on my back and will continue to kind of advocate for over the years, just because you don't know what you don't know. Right. So it's like these people follow me for all types of things. I'm gonna give you this. Awesome.
Awesome. Thank you. Okay. I have one more question. This is for everyone. And we could start with Paula and just move down the line. But what's one piece of advice you would provide to our viewers if they're interested in promoting health justice and fertility equity in their day-to-day life?
Yeah, I would say, kind of piggybacking off of you, Amanda, like talk about it. Just be very vocal about your own health concerns. Just like really like let's be open in our communities about what it is that we're going through so we can support each other. And then even more specifically, I would say to vote for and advocate for policies that are providing healthcare more affordably for more people. So I'm big on like we need universal healthcare. So things that are moving us in that direction, let's keep our attention on that and our support for those kinds of things.
And in addition to that, I think that it's important to advocate for certain types of healthcare coverage, even within your own like institution, wherever you work. It's important that they know that people are seeking this type of coverage. But beyond that, just really trusting yourself. If you are somebody who is struggling to conceive, or you know somebody who is like really trusting that you know your body, like that there's nothing wrong, you know, with like so there's nothing you did wrong. It's nothing that should be it shouldn't have to weigh you down that way. So speak up so that way it doesn't have to continue to. And if somebody isn't listening to you, go to somebody else. Like I know that's way easier said than done, but in the end, we have to like look out for ourselves as these policies are passing over the years, which is a long game. It's a long game. We aren't there yet. So recognizing that and doing what you can do for yourself to advocate for yourself in all of these spaces that you might find yourself in.
That's great.
Absolutely. I'll piggyback on that. I'll just say, you know, advocate for yourself. Good, you know, women, we get an annual exam, or we should get an annual exam with our OBGYN once a year. And that's a time for you to just talk about your cycle and your fertility concerns. It's like a 5-minute conversation. Are you trying to get pregnant? Can I do a fertility check? Can I do a hormone level to check on the egg supply? Just to kind of speak on those things. And like Amanda said, if you're not getting that response that you're looking for from that provider, seek another opinion. It is okay, but we have to advocate for ourselves and make sure that we're being served, we're being heard and seen, and that we're getting what we need.
Exactly. I piggyback off that. I feel like, you know, as we're working on these policies and all this systemic change, we need to arm ourselves with information. We all know that cheesy phrase, knowledge is power, and it's really just the case. And so don't be afraid to ask your clinicians questions or go to some of these advocacy groups like Fertility for Colored Girls that exist out there literally for this purpose, for you to come in this judgment-free way to just get some information so that you don't feel as strange about asking your questions. Like when you know a little bit of something, you can ask questions kind of from that informed place. Right. And so just please get that information. It's out there and start to have the conversations in whatever way you feel comfortable with, right? So Amanda's out here on her platform. That might not be for everybody, but you can go find Amanda on her platform and it might feel like a safer way there and see that there's this community of folks around you. So I just highly want to just amplify that. In addition to the mental health piece, which is also another kind of way to advocate for yourself, but just want to reiterate, if we haven't already said or say for the first time, that when you're starting to think about whether infertility might be something you're struggling with, once you get the diagnosis and you're going through treatment, it's tough. It's stressful, like to say the very, very least. And there's a lot of emotion and emotional roller coaster that goes into it. And so find you a mental health care provider, especially somebody who knows a little bit about pregnancy and birth and the perinatal time and can support you through this.
Very good.
Wow, so hard to go last. Like that was all like really great, and this has just been like a really amazing and rich conversation. And I think my takeaway for folks would just be, again, to just be a voice for, if you can't be a voice for other people who maybe can't be a voice for themselves, because everybody can't be an advocate for various reasons. So always just trying to continuously educate yourselves and be advocates for people in, like y'all said, like ways that you know how to be. It doesn't have to, everyone thinks that advocacy has to look like a certain way, but there is no one right way to do it. So finding what works for you and going out and sharing that.
So, Dr. Clarke, I don't know if you want to share any ways that people can get involved in the research that the Center for Maternal Health Equity is doing.
Yeah, absolutely. So we're going to be doing more waves of this study. Like I said a little bit ago, our sample, maybe I didn't say our sample was mostly married and heterosexual women. And so we realized that we're missing people here. And so we want to go specifically and see what's up with our queer family, what's up with our trans family, what's up with people of different incomes and education statuses who are single and wanted to have our children, or at multiple intersections. They're single and queer and looking to have a child, right? Like your experience really, really matters, and we want to understand what your needs are. So if you are interested in kind of sharing your story with us, that is definitely one avenue, and I'm happy to share my email address, which is lsclarke@msm.edu. So, and Clarke has an E at the end, so lsclarke@msm.edu. And like I also mentioned, get in touch with our partners, SisterSong, Spark Reproductive Justice. They all have IG platforms, and they're all moving and shaking in this space and trying to make those systems level changes happen so that our individual level lives go a lot more smoothly in this space.
And the resources that you mentioned and that your email, we'll put that in the notes and everything.
And Amanda's platform as well.
Exactly.
Yeah.
Well, thank you all again for tuning in and joining us for this amazing conversation. And thank you. Bye, y'all.